Hello, I'm Dr. Darryl Kaelin, Associate Professor and Chief of Physical Medicine and Rehabilitation at the University of Louisville and Medical Director of the Fraser Rehabilitation Institute. I'd like to take a few minutes to talk about my career as a physical medicine and rehabilitation physician, but also to talk about a day in my life. Physical medicine and rehabilitation is one of 24 board-certified specialties that deals with treating people with illness or injury that has resulted in a loss of function and to help them recover to their fullest potential. Physical medicine and rehabilitation can also cause some confusion for people, as it is a relatively unusual field of medicine and does not necessarily focus on one disease process or one organ system. So we like to think of ourselves as specialists in function, but we deal primarily with the musculoskeletal and nervous system. We provide services in a variety of settings and are often thought of as the primary care providers for the disabled population and those with chronic illness. Many of us, such as myself, deal a lot with neurological problems and neurological trauma, such as traumatic brain injury and spinal cord injury. I'm a medical doctor with an MD degree, but you can come into our specialty through either allopathic medicine with an MD degree or an osteopathic DO degree. I think that both of these lend themselves well to understanding the medical problems that our patients have, but also the musculoskeletal and functional problems that they often face. You might ask how I came to choose physiatry, as we call it, as a field of specialty. And I would think that my career path is similar to many in that I found a fascination with patients who had lost independence and lost function and were really being challenged by their life and really wanted some answers as to how to reduce their pain and how to improve their independence. I had a sports medicine background, or a sports background, and I looked at physical medicine and rehabilitation as an area where I could act somewhat like the coach and take the patient and set goals for them and direct the team that included the patient, their therapist, their family and care providers, and many other ancillary staff to provide a cohesive and interdisciplinary plan of care that would result in the fullest and best outcome. Over my career, I have practiced in a number of settings, and those include private practice with a group. I've been an employee of a hospital system, and now most recently I have been an academic faculty member at the University of Louisville. Throughout my career, the one thing that has been stable has been my love for teaching and for research, and I've been lucky enough to have a resident with me throughout my career in all the settings that I've been in, and to perform clinical research in all of those settings as well. My current role includes clinical practice, which is about 60%, administrative work, which is about 30%, and research, which is about 10% of my weekly schedule. I currently practice in an academic faculty model at the University of Louisville, but as the Chief of Physical Medicine and Rehabilitation, part of my responsibility is in recruiting and supporting the program development of my fellow physiatrists, as we like to call ourselves. And I have 10 physicians in my department that span a variety of subspecialties that really show you the breadth of our field. I have physicians who specialize in pain management, cancer rehabilitation, pediatric rehabilitation, musculoskeletal medicine, geriatric and subacute rehabilitation, as well as the standard practices of general rehabilitation, including inpatient and outpatient care. Some of our physicians specialize in spinal cord injury, and physicians such as myself specialize in acquired brain injury, including traumatic brain injury and stroke. I enjoy my current practice situation because it allows me to carry on the various roles that I've described. I see about 12 to 15 hospitalized patients at the Fraser Rehab Institute every morning. I work with the staff and a resident to coordinate their care. adjust their medications, order specific therapies and types of equipment that will help in their recovery, and educate the patients and their families on how they might best resume a more normal and independent lifestyle. I then move into my outpatient clinic setting, where again on an average basis I may see 6 to 8 patients in a half day, or about 20 to 25 patients over the course of a week, which allows me to follow my patients through their outpatient recovery and to assist them with some of the problems that they face as they enter back into the real world. I think that my role on the care team is an important thing to mention, because one of the things that really sets physical medicine and rehabilitation apart from other specialties is our specific training and expertise in providing leadership to the care team. We're often looked at as the care coordinators and quarterbacks of a team that includes other specialties such as internal medicine, orthopedics, neurology, and psychiatry, but we also coordinate the care among the therapist, nursing staff, and even the patient and their family themselves in order to obtain the best outcome. Many people ask what separates physical medicine and rehabilitation specialists from other specialties such as orthopedic surgery or neurology. My answer usually is something along the lines of, well, we don't perform surgery like an orthopedic surgeon, but we take care of all of the non-operative orthopedic problems that people have and some of the post-operative recovery that people have after things such as joint replacement or trauma. And unlike a neurologist, we don't always necessarily make diagnoses like Parkinson's disease or MS, but we are better trained to understand how to maintain a person's independence and improve their function after such neurologic problems. As an example, I specialize in neurological rehabilitation and have an interest in spasticity management. So many of my patients develop spasticity or tightening of the muscles after the nervous system's been injured, and so I'm highly trained on looking at different alternative treatments, which might include things such as nerve blocks, botulinum toxin injections, medications, intrathecal baclofen pumps, and even referral for certain specialty types of surgery to help reduce their spasticity. Over my career, I've had a number of very interesting patients, but thought it would be interesting to kind of highlight a couple of those to you that would give you an example of the types of patients that I see and that people in my specialty see. One recent patient that comes to mind is a young lady who fell about 50 feet and suffered a severe traumatic brain injury, as well as a very complicated pelvic fracture. As a result of this, she was in a coma for about 2 weeks and was very minimally responsive when I began treating her. In addition, she had significant weakness and pain in the low back and in the legs as a result of the fractures and the injury to the nerves that come out of the back and run down the legs. I had her in the hospital at the Fraser Rehab Institute for a number of weeks, during which time she became more alert, more responsive, more oriented, her memory improved, and by the time she left, she still had cognitive difficulties, but was much more conversive and able to interact and have a higher quality of life. In addition, we provided her with medications and treatments that not only reduced the pain in her back and legs, but helped her to participate better in therapy and regain some of the function she had lost. I did a nerve study called an EMG on her legs, which showed that she had had damage to the nerves that come out of her back and run down her legs, and gave her some prognosis for what the time frame for recovery would be. Now that she's about 6 months out from her injury, she has regained a full level of independence. She can be left alone. She has started taking some online courses and is walking without any assistive device with just a slight limp, and has shown a significant degree of improvement in both her strength and her balance. The hope is that she'll return to school this fall on a part-time basis. So as you can see, there's a great deal of reward in helping take people from such a low level of function and helping them to regain their lives with hope and dignity. Many of the patients over my career have come to me with various problems, which might include neck and back pain, carpal tunnel syndrome, neuropathy caused by diabetes or other problems, weakness in the arms or legs that may come from myopathies or muscular dystrophies. And so as you can see, we have a wide variety of patients, all of which can provide us with a very interesting and dynamic array of problems that we might face. The one thing that ties all of these together is function. And as mentioned earlier, rehabilitation specialists view themselves as functional specialists. And I think that we can really help anyone who has lost function or has significant pain in helping to regain their lives. In closing, I hope that I have given you a better view of what physical medicine and rehabilitation is about, how you might get to being a rehabilitation physician through medical school, leading into a residency in physical medicine and rehabilitation, and then potentially going on to fellowships that would subspecialize in a number of areas that I've described, and ultimately the many different wide career paths that individuals in our specialty might be able to go into. I invite you to learn more about our specialty by listening to some of my fellow members' stories. And for more information on a day in the life of a physiatrist, you can contact the Academy at info at aapmr.org or visit our website www.aapmr.org. Again, this is Dr. Darryl Kaelin. Thank you for listening.